Here we discuss an ECG showing isorhythmic atrioventricular dissociation and its clinical correlates. Isorhythmic AV dissociation is one of the three forms of AV dissociations which can be noted on the ECG. Complete heart block is the commonest form of AV dissociation with which we are familiar. In complete heart block, the atrial rate is more than the ventricular rate, while in isorhythmic AV dissociation, the atrial and ventricular rates are almost equal. The other form of AV dissociation is interference AV dissociation in ventricular tachycardia. In this, the ventricular rate is more than the atrial rate. It is called interference AV dissociation because the impulse conducted down from the sinus node and up from the ventricles interfere with each other in the AV node. Isorhythmic AV dissociation occurs when the sinus rate is slowed down and junctional rate is accelerated so that they are almost equal. The atria are captured by the sinus impulses and ventricles by the junctional impulses. In the ECG, P waves are clearly seen to be dissociated from the QRS complex. Atrial and ventricular rates are similar. Most of the P waves occur during the ST segment. When the P waves occur during ventricular systole, atrial contraction will produce cannon waves in the jugular venous pulse because the right atrium is contracting against a closed tricuspid valve. Ventricular systole is from the peak of R wave to the end of T wave. P wave occurring during this period will produce a cannon wave. Another interesting clinical finding which can be seen in isorhythmic AV dissociation is reverse pulsus paradoxes. In reverse pulsus paradoxes, the pulse volume decreases during expiration. Here the pulse volume increases in inspiration because of increase in sinus rate which causes AV synchrony. During expiration, sinus node slows down and junctional rhythm takes over, producing AV asynchrony. An important journal reference on reverse pulsus paradoxes in New England Journal of Medicine. Reverse pulsus paradoxes is an expiratory fall in pulse volume, the opposite of pulsus paradoxes. The classical causes of reverse pulsus paradoxes described are isorhythmic AV dissociation, hypertrophic obstructive cardiomyopathy, and intermittent positive pressure ventilation. In isorhythmic AV dissociation, inspiratory increase in sinus rate results in sinus rhythm dominating over AV dissociation. While in sinus rhythm, there is AV synchrony and hence higher pulse volume compared to AV dysynchrony in expiration. The ECG shows the typical fluctuation in P-QRS relationship with nearly identical atrial and ventricular rates. In isorhythmic AV dissociation, inspiratory increase in sinus rate results in sinus rhythm dominating over AV dissociation. While in sinus rhythm there is AV synchrony and hence higher pulse volume compared to AV dysynchrony in expiration. The ECG shows the typical fluctuation in P-QRS relationship with nearly identical atrial and ventricular rates. During IPPV, the swings in intrathoracic pressure is opposite to that of normal breathing. Hence, the inspiratory blood pressure is higher than expiratory blood pressure. During the inspiratory phase, increased intrathoracic pressure of positive pressure ventilation is transmitted to the aorta. In addition, there is an increase in the left ventricular stroke volume. The occurrence of reverse pulsus paradoxes during IPPV has also been called as respirator paradox. It has been mentioned that respirator paradox after cardiac surgery may delay the early diagnosis of cardiac tamponade. Reverse pulsus paradoxes in a patient on IPPV is thought to be a sensitive indicator of hypovolemia. LV and systolic volume as measured by radionuclide imaging is reduced during inspiratory phase of IPPV without significant change in end diastolic volume. This would suggest a reduced LV afterload in inspiratory phase as a mechanism for reverse pulsus paradoxes in IPPV.